All right, y'all, it's 10 o'clock. We're going to go ahead and get started. Happy Monday. Hard to believe that it's already the end of April. Seems like time is just flying, that's for sure. I'm not sure what it is, but it certainly is. I believe we do have a quorum. We've got 6. I don't think that's all us, though. 16, Gabby, is that correct? 14.
Yeah, not involving Katie, Liz, and myself, it would be 15. It looks like it's climbing though.
Okay. Well, maybe we'll just wait a minute. How many do we need for a quorum? I can never remember.
I think Liz and I discussed this. I think it was it 25, Liz?
Yeah, well, no, 25 is your number because you have several in the Wellstar system that are covered by one, as well as like you, Michelle, covered 2, and then AU covers 2, and Memorial has a few. So I think 25 is the number. So half of that, which is following the commissions, is 13. It's just a simple majority. So you're probably there.
Okay,
Yeah.
perfect. Great, then we'll just keep following the agenda. The minutes were sent out by Gabby last week. Thank you so much for that, but we do need, unless there's changes, we do need approval of the minutes from our last meeting when we were at Chateau Elan. Can I get
Michelle D. Burkett, I motion for approval.
Great, thank you, Dee.
Yes, ma'am.
Can I get a second?
This is Patrice Walker. I'll second.
Awesome, thank you so much. I appreciate it. All right, so next on the agenda, Liz, I'm going to hand it over to you. I know there's been some action and some movement since our report came in. So just want to hand it over to you for some Trauma Commission updates.
Sure. Thanks, Michelle. Good morning. Sorry, I looks a little bit like I'm in my mugshot here but I'm over at the Office of EMS and Trauma. We're in a report writer class today. So coming to you from their offices just south of the airport. So a few updates. The legislative session was a bit of a nail biter. It came down to the very end, about a week before the end of the session. Somehow $692,000 was removed from our budget. And thanks to several of you, your government affairs folks, as well as several of our commission members, the message got across loud and clear that we need more money. We don't need less money. So we were successful in getting that reversed. I think that was just some posturing and some, there's always a lot of negotiation when it comes down to the end. But I think the lesson here is that when the trauma trust was set up after we were the benefactors of that legislation that dedicated our money to us, it just goes to show that you almost can never take your foot off the gas pedal because these kinds of things can happen. And luckily it worked out to our benefit, but it was a little bit scary, and the budget wasn't passed until the very last day of session. And so we are scrambling now a little bit because we were a little afraid of that budget cuts, and now we're trying to figure out how to reorg everything. And as this group is well aware, our group has grown quite a bit. There's been the addition of a few more level 4 trauma centers. We have a new level 3 trauma center, Piedmont Henry. And it's kind of a balancing act now. $23 million is a lot of money, but when you're spreading it over 35 centers or trying to give everybody a fair piece of the pie, unfortunately, that means existing centers are going to get less money. So the budget committee has the hard task now. We met, our meeting ran over an hour over time, and just trying to figure out how to work this all out. In addition, it doesn't leave us additional money to recruit centers in areas of need, and we still have to fund all the things that we're required to fund around EMS. So a little bit tight. We're having another called budget before the commission meeting. It sounds like somebody's line is live. If you can mute your line, that'd be helpful. Thank you. So more to come on the budget, but it looks like with the called meeting by the committee, it looks like the final budget will be approved not until the commission meeting, May 25th. We like to do this a lot earlier. Many of you know that in years past, you wouldn't get your contracts for your trauma centers until sometime in August, and we don't ever want you to be a month or 2 months into the fiscal year before you receive a contract. But unfortunately, our target date of June 1st, I've already told Katie to kind of take a deep breath. There's just no way we're gonna, it's gonna be really hard to get contracts out by June 1st. So we'll shoot for the 15th. And many of you, your legal teams are very accustomed to turning these around quickly. So thank you for that. The next big update is really relative to the ACS consultative visit. We have reviewed their preliminary report. We spent a while on the phone with them a week ago today to do some edits. There were some content edits that weren't major, but just enough to make the report clear to those folks who are reading it. So we hope that we will have the final report should be out, I'm thinking within the next 2 weeks. So we'll look forward to that. We will post it and we'll let all committees know, because many of you had a stake in that. And thank you to all of those who were able to attend the stakeholder meetings for that. That was really helpful. We've had a few RTAC coordinator transitions. We're just in the middle of contracting for a Region 4 RTAC coordinator. A few trauma centers now in that region, as well as Region 9. We have a couple interviews coming up this week for a contract for Region 9. So hopefully we can make those RTAC transitions smooth. That really helps many of you, your leaders in your facility, your trauma medical directors, trauma program managers, or in some instances, even your ED docs serve as chairs for the RTAC. And we really appreciate those volunteer efforts, because volunteerism is hard these days, and everybody has so much on their plate. So the RTAC coordinators through the contract with us, it really fills that role of doing the minutes, getting everybody together, all the committees, all those other things. So I want everybody on this call to know we're trying to support those things as best we can, but it's hard to even keep those contractor positions full. One of the things we hope to roll out to you soon is myself and Gina, our GQIP director, are working closely with Office of EMS and Trauma to build a true trauma dashboard, similar to what many of you have in your facilities, that just at a glance, you can tell from a very easy, red, green, yellow sort of fashion, kind of how things look from a statewide perspective. Some of the things that we still need help from this group, and I think, Michelle, you have it on your list. And one of the things that we heard loud and clear from the ACS is that we don't have a good way to track trauma diversion. And many people will not accept, many facilities, trauma centers will not accept transfer patients, but they're not considering themselves on trauma diversion. So it would be helpful if some recommendations. I know that there was a group originally put together to look at this, and the group felt like it didn't have really its authority to really do that. But I think through the Office of EMS and Trauma, they could put something like this in rules and regs. So I think it'd be worthwhile to craft a recommendation from this group of what that might look like. And if it's something that all the trauma centers can sign on to and agree to hold everybody accountable, nobody has additional bed space. So on some level, we have to figure out what the load balancing piece for that kind of looks like. And Michelle, I know you'll talk about GCC a little bit later, so that probably ties into that. But anyway, then the dashboard, it would be very important to get something like that on there, so we can sort of know what the health of our system is looking like. And then, because my OEMS&T colleagues are in the report writer training right now, the only important update I can think to share with you from their perspective is that they are hiring for Renee Morgan's old position, and the interviews for that were conducted last week. So you should be hearing something fairly shortly on that. And the last thing I'll share with you is that you all may be familiar with the Mission Zero legislation that passed and was at a federal level and was actually funded. It didn't get as much funding as we wanted, but I think, Michelle, Grady got some of that money because it's for the military civilian installations, essentially keep military surgeons ready. It's hard to have, a general surgeon practicing doing APPEs laparoscopically and then get called up to duty and have to go deal with, some of the sophisticated injuries they see on the battlefield today. So in order to support that readiness, several centers around the country were given funding to support that military civilian integration to ensure that our trauma medical teams are ready, military trauma medical teams are ready to go as called up. And then we just got word that I think it was on the 13th. Yes, that's what the letter is dated. There was another piece of legislation that was passed at the same time. And that was improving Trauma Systems and Emergency Care Act. And to be honest with you, even last year when we joined the TCAA lobby group to talk about both Mission Zero and this Trauma Systems and Emergency Care Act, it was a little nebulous because we weren't exactly sure what they were asking for as that. But literally, they really do want to improve care in rural areas and ensure that there's a coordinated response like across the country. So it sounds like the best proposal yet. But now, just like Mission Zero, they're asking for money to fund it. So the first thing is always to get the legislation passed. The second thing is to try to get it funded. And then the third thing is to try to increase the funding. So right now, this is the first stab at getting money, and they're asking for 24 million. I have no idea what this might, I've already had reporters reach out to me and ask me, what would this look like for Georgia? To be honest with you, I'm not really sure. Since I'm here with my colleagues today at DPH, we're certainly going to talk about this. I'm not sure how if they would open up grants or, you know, or if this would be a certain amount divvied out per state. We don't know how this will work yet, but stay tuned on that. We'll certainly fill you in. And I believe that concludes my updates, Michelle, unless there's any questions. I'm trying to monitor the chat box as well. So if you don't want to speak up, but you want to put something in the chat box, please feel free.
Any questions for Liz? So yes, we, I know Grady was one of the sites. We already have a military surgeon here, Dr. Franklin, Ben Franklin. And I know we are getting 2 nurses this summer, and I think another physician. I'd have to verify, but I know for sure that we're getting a trauma nurse and a SICU nurse that will be transferring in this summer. So very excited to be a part of that. I think it's great for Georgia. And I think it just really gives us that next step of few states that had the opportunity to do this. I think it's a great thing for our statewide trauma system. All right, so trauma transfer diversion update. So it is still live in the system. There's very little usage. We're getting ready to hit summertime where volume is going to be extremely high, as it typically has been. I think everybody has been seeing increases year over year, pretty statistically significant. So please, we've sent out multiple times, sent some information out. If there's any questions, Lori is very willing to do additional education for you and your team, or if there's questions about access. But that is a way that right now the state is using to be able to look at all centers, and EMS is using very religiously to being able to see how the status of the hospitals and what they are doing and what the needs are. So are there any questions about the trauma transfer diversion?
Hey, Michelle, it's Becky Weiler from Northside. Did want you to know that we are utilizing it. We just haven't had to. So I didn't want you to think that we weren't. I think I've had to use it, I think, one time. And we did do it for 2 hours. So I'm also capturing that data, but I just wanted you to know that it's built into our process now here at the Gwinnett campus. And if we are going to use it, what does it look like? When does it look like? So grateful that we haven't had to. Like many of us, we are committed to making sure that that arm of our business is always open and those patients are able to come into the ED regardless of the fact that we're holding other patients. So I just didn't want you to think the lack of us, you seeing us using it doesn't mean that we weren't. We're just really committed to not having to do that.
Absolutely. No, I completely understand that. We are doing what we've had to do lately. And matter of fact, I'm executive on call this week, and we're probably not far from it, is total diversion except trauma. Like, we've not closed our doors to trauma. I mean, we really can't, quite honestly. But it's hard, and it's a commitment by the organization. And so I think let me back up. Does anybody else have any questions? Because that leads to another conversation. So thank you, Becky. Does anybody else have any other questions around that?
No questions, but I would just echo that. This is Patrice Walker from Navicent. We do use it as well, but we try very hard not to go on trauma transfer diversion. We certainly go on diversion more general diversion more than we would like, but we really try to avoid any kind of trauma related diversion.
Yeah, I think that's the great thing about our network is I think everyone understands their commitments to our patients and really understands the different level of resources that are required for trauma patients, trauma and burn, quite honestly, because I was looking at some case mix index stuff this weekend and we got some really sick patients. I'm sure that's the same across the state. It's not just isolated in one area. So I know everyone is seeing some pretty high acuity across the state. So one other quick update is Image Trend. So that is the new platform for the GCC that will then be able to help us create communication groups and other variables that will be able to send out communication when we hit a status. Unfortunately, it's out of our control around when it's getting completed. And anytime you have an external partner, you're at the mercy of their schedule. And so it's a little bit behind, but Lori's telling me hopefully in the next 4 to 6 weeks that hopefully that will be updated and then we'll be able to do some more education and training and create those work groups. And that really ties into next steps. So when we met in February, March at Chateau Alon, we talked about this trauma center diversion and communication work group. But quite honestly, you know, I think for me, sometimes the best meeting is the meeting after the meeting. And I had countless conversations with many of you all about just operations. And I think as an executive, if we try to put trauma in a box and only focus on trauma, we're going to miss something. And I know for a fact, you can't go to your executives and say, your CEO, CO, whoever, and say, hey, we just need to focus on trauma and nothing else. And so lots of conversation about best practices, ED throughput. And so want to open up the opportunity as we wait and plan for the new update with Image Trend and the communication work group. If there are folks that are interested in having that conversation about ED best practices, Francis and Amy did a great job, and we sent this out to the team in November, putting together like a template, or not template, Francis helped me, kind of like a leading practice document of things that they had seen, that they had gathered. And, you know, I've been in emergency medicine for almost 30 years. And, you know, a lot of what we do is pretty predictable. And so it's a lot of times it's very nice to learn from others and hear what they are doing, looking at surge plans. Becky, you were just mentioning yours. You know, Angela, we've talked about in the past with you, you know, what opportunities do we have to network? Because at the end of the day, if we are focusing on it before we get there, then we actually are preventing trauma diversion. If we can focus on the bigger picture and what that looks like. So if you are interested in doing that, happy to pull that group together. Again, I had multiple conversations in February, March, with many of you all just picking brains about what the opportunities were. So I don't know if there's any discussion or thoughts around that.
Hey, Michelle, Becky again. I don't know if I saw that document that you just referred to. It might have gotten lost in the emails. Could you resend that just so that could be a refresher
Sure.
to the group? And then, yes, I absolutely think as people that deal with this every day, there's no one better to work through the issues that we're dealing with. So totally would support an active work group on this subject and how we can really have good conversations with our peers and those above us and around us. Because as you say, and as we all know, trauma is just one section, one group, one patient population that everybody is passionate about. That's our focus today for trauma. So would definitely support a group that would be discussing some best practices.
Great. Does anybody else have any feedback or thoughts? Checking the chat. All right. Well, if you are interested, yes, I will send that document out. I believe I'm sure I have it saved in my files, so I will send it out from Francis and Amy, and they did all the work. They did some really great work about pulling that together. So I will send that out to everyone. And then let me know if you're interested in further conversation. This would be separate from our regular meeting. This meeting is meant to be more of updates and any actions that need to happen. I'm capturing everybody in the chat as they pop up. Versus a work group. Like the work group really needs to happen outside of this group. So if you're interested, let me know. I've got a few names already. That'll be great. Before I open it up to any for the rest of y'all, if there's anything you all want to bring forward, I do have an email or an update. Liz has talked about the funding, and I kind of was closely watching that. Our GR guy Ryan is phenomenal, and I know he was knee deep in helping support some of that. But we do, as Dr. Ashley has mentioned to this group before, really looking at our trauma funding, sustainability, and what that looks like moving forward. So I know that there will be a smaller group, particularly around the level ones that are pulled together to talk about what that would look like. And as I've mentioned, and I'm sure others have, particularly at the statewide meeting, you always have to put yourself in perspective of what's going on in the state. And Medicaid expansion has been a big hot topic. While we're not there yet in Georgia and North Carolina just got it. So hopefully it's getting a little bit closer for us, which will definitely impact funding. But what does that look like for Georgia? And I will tell you that I've been a part of the commission, at least from the fringe, since it started back in 2008, and was one of the ground stompers for the tag tax. And I'm not saying or promoting that, but understand the sustainability and the funding that is required around that work. So I know we at Grady have discussed, and if others would like to participate, we're just going to do a snapshot of what our funding actually is versus what we report out, what we have to report out, what's taken in, what's taken out, but truly understanding the dollars that we are providing to ensure that we provide the level of care that we are needed. Things like 2 trauma surgeon attendings in-house 24/7. That's not by regs, but that is something we know we need to do to keep our patients safe. So that's something I know the finance work group. I need to touch base on that one with the folks that are leading that. But there is some opportunity that we as a state can come forward and decide what it is that we need. Whether we do that in the next year or the year after, I think there's an opportunity there. So just understanding those components and what that means. And it's different by region. It's not the same. And costs are different, supplies are different. There's lots of different pieces of that around funding. So more to come on that. And we will, I'll share as we move forward. I know I've sent an email about getting some meetings set up, hopefully beginning in May, June, around that. So just a small update, but more to come. And then just wanted to, Patrice and Tracy, great. Dr. Walker, excuse me, I'm sorry, call physicians by their first name. Wanted to open up to the group to see if there was anybody that had anything else they wanted to bring. I don't believe in belaboring meetings. We schedule hours because it's a standard, not because it needs to be. So wanted to give the group open forum if there was anything you wanted to bring forward, any questions about items that we've talked about today, or anything of interest that you think we need to be focused on moving forward. So just give y'all a minute or so to share or chat in the chat box.
Hey, this is Patrice Walker. Just wanted to mention, so we did have our trauma survey, our ACS trauma survey last week. We're all extremely excited that that's over with, but it went very well. And Tracy Johns, our trauma director, is on the line. So Tracy, is there anything you think we should share with the group in terms of things that that other hospitals may find useful that the folks talk to us about?
I think my biggest takeaway, this is my 3rd survey, and in the virtual realm, you have to get your documents in so much further ahead, like 45 days ahead of your survey. You have to have your PRQ to the surveyors, and then those then they want to see documentation on select areas, you know, like 2 weeks ahead of time, along with medical records. They are so much more thorough in the medical record review. I had to kind of do a self-check because, you know, they're not criticisms, but they are, you know, the lead surveyor, or one of the I had the second surveyor I was in there with, but the lead surveyor told me he takes 3 days and he actually picked out 11 or 12 records. And, you know, so he really takes time to go over that stuff. So that takes a lot of coordination and a lot of effort that might be, it might exceed your trauma admin staff. So I would say be prepared for either overtime or help, because they want a lot of, you know, so much ahead of time. And the surveyors like this. And I think going forward, both surveyors mentioned that they're going to probably do this as surveys as a hybrid format. So they get all the documents ahead of time, but maybe come in for just half a day to do this tour and talk to different people to really confirm what you've sent them. So just a lot of heavy lifting on that data ahead of time. And so that was our biggest, I think, stressor. But overall, they were very complimentary about the state cooperation, collegiality, and the accomplishments at the state level. Thank you.
That's great. Thank you both. I think it's always good wisdom to share what others have been through to learn, because they tend to sometimes follow a pattern. So great.
Yeah, and the only thing I would add in terms of administrators is, you know, we're all looking at our budgets and FTEs, but you know, one of the take homes that I got is we're going to have to put some resources into some positions that we currently don't have here. We're going to be needing an additional social worker probably. That was one of the opportunities that was identified, as well as, of course, another what is it, coordinator, I believe, just to meet the new standards that are coming out. Based on just our volume of traumas, we will need to hire at least one. So I know FTEs are at a premium. So that's something that as administrators, we will need to be aware of that. You know, we've just talked about the resources that it takes to keep our programs functioning. So we will probably be having to put some additional manpower resources just to meet, you know, these are not extra. So I think as administrators, we have to make sure that our you know, leadership understands that these resources aren't extra. These are the necessary resources needed, you know, to meet the standards of being this trauma center. So I think those were my take home points.
That's interesting. The social worker. So were they wanting to see a social worker dedicated to the trauma team that went with the trauma team, not assigned to the units?
Yeah, I'm trying to read my chicken scratch notes here.
I think, if I may, Dr. Walker, interject. Yes. I think the way that our program is set up, currently we had help from our psych department for our expert needs. And so when we were looking at the best way and the most efficient way to, you know, meet the needs, expert again was our only deficiency, mainly because changes in psych and the amount of therapy they have to deliver took away that person that was supporting our expert interventions. So we didn't have any one person in our department that was doing anything. We've identified needs as far as discharge planning, you know, with the trauma patients being a very mobile, you know, they might hang out in, you know, those really critical patients, they're going to hang out in ICU a couple of weeks. So if you don't have a discharge planning group that, you know, when they're department based, by the time they get to, you know, the floor, they're not going to be there long, or either they're so complex because of family dynamics or their needs, and you don't have the insurance coverage. That's where the complexity comes in. And so that, you know, the discharge planning needs, the expert needs, and then upcoming in fall of this year, there are going to be 2 more mental health requirements of level 1s and 2s. I'm not sure, I can't remember exactly about the 3s, but about PTSD and depression screening. We just felt like, or the surveyors felt like, that our needs could best be met by a social worker. So I think that's where that idea came from, you know, and we talked to them at length about it, you know, just understanding that, you know, we could do that with a nurse, with PI, but again, that was taking away from PI. They're really expecting to see everything documented, whether it's PI or expert, or, you know, it's kind of like proof. And so as a whole, that's what we felt like would best meet the needs of our program and our TSN. That's also emphasized in the new standards. So like one of the first things I'm going to do after looking at any weaknesses they identified is looking at what are our gaps with the new standards. And, you know, because there's several things, they're raising the bar as far as the standards. So for the level 1s and 2s, that really puts the pressure on the admin people to support and make sure those standards are being met. And whereas in the past, we've been able to use people from other departments kind of almost sharing an FTE, but they really report to psych, which is we've done very successfully for 6 or 7 years and met our expert, you know, needs. But it's now with these other things, it's just, that's where they felt like, and that's why they kind of said that in specifics. But, you know, of course, the hospital could meet that need however they felt was best. But, you know, they were really complimentary about talking about how they liked how we worked with other departments to try to fill the needs, you know, and as Dr. Walker said, she gets a lot of pressure, you know, about, you know, maintaining or keeping the number of FTEs down. So it's a balancing act that I think you as administrators all have to, you know, meet. But, you know, there's just a lot of things, and looking at the, you know, increased staffing requirements for the registry, because it's all about the data now, whether we're sending it for our ACS survey or for our national benchmarking or for our state benchmarking. It's all about the data. So if you don't have good data, you have enough to not only abstract it, but validate it. So that, you know, adds another half FTE to an FTE there, depending on your volume. So those are things that I feel like came out of that talk. And I just kind of realized how they're focusing the more holistic approach to the program in these surveyors and in their comments. I don't know if Dr. Walker would see it that way, but that was my takeaway.
Hey, this is Mark Schreiber over at Augusta University Medical Center. We as well just completed our survey on Friday. Just a couple of days ago, and with positive results, thanks to you know, really in part a large part to Regina Medeiros and her outstanding team that kept everybody organized and on track and kept riding us. And I know there was a lot of pre-work that her and her team had to do as well. At the moment, the only deficiency, I guess, was about the registry as well, due to some staffing challenges, not having enough currently, and then not closing records, you know, appropriately enough. And that's something that we're going to work on. Shouldn't be a hard fix. But I second the comments on social work. They did allude that next time they would like to see a dedicated social worker to the trauma department for all the reasons already mentioned. So I echo that. But other than that, it's a pretty outstanding survey. A little bit difficult being only virtual.
Congratulations to both of you. And yes, we went through the virtual one a few years ago and it was a little bit of a challenge. For sure. Does anybody have any questions? You know, this is the best way to learn. We're in our data year, so we're actually actively trying. I think ours is scheduled for the end of March next year, I think was the target for us to get ours completed. So we're having all these conversations internally. So it's always good to hear from others. Because they tend not to change, they tend to grow and feed upon. So it's really good feedback. Thank you both to Dr. Walker and Dr. Schreiber. Anything else? Any other questions for them? All right. right. And yeah, I do appreciate the fact that trauma is becoming a little bit more holistic. I know we're doing some work around trauma-informed care here, particularly in our trauma patients, and really understanding what drives them to trauma in certain cases. And so it's been some really good work, and appreciate that the ACS is hearing that as well and wanting to do some focus on those pieces. All right. Well, we've got about a little over 20 minutes left. So I'll give that 20 minutes back to you in your day. The only follow-up I have presently is it's the Trauma Center Diversion and Communication Work Group, but until Image Trend is ready, we can go ahead and start some of that work with an ED operations or hospital operations, then pull into what does that look like for trauma center diversion, and then communication once Image Trend is up and running. So I will tell you, I'm on call this week, and I am out of the office at AONL next week. And the week after that is Nurses Week. So we're in full steam ahead here. So probably be around mid-May before we had that first meeting. So look out for Survey Monkeys to see when we can make that happen for those of you that are interested. But please just shoot me an email if you're interested in being a part of that. Our next meeting is in July. And if you have a chance, I know that Gabby sent out the information for August, and I think it's in Savannah. If I read that correctly, I may have read that wrong.
Yes.
Okay, so I'm not losing my mind. I have another meeting in Savannah in September that I don't normally go to, but I was glad to hear. So in Savannah, a little bit closer than St. Simon's, and definitely beautiful. So
And Michelle,
go ahead.
just so the administrators know, their presence is not required at the August meeting. We made just once a year for the in-person, because we know your time is so valuable and is so hard for you to get away. But let us know if you're interested. Honestly, we really booked the venue. St. Simon's, the King and Prince, is just a little tight for both GSACs and GQuIP. It's one of those growing pains thing that we've just gotten a little big for both groups to be at the same venue. So we didn't, and many of you were, if you came, you were impacted by that, even though administrators weren't required last year either, but some of you came and a lot of people had to stay off site. So we didn't want to have that happen again.
Yeah, no, absolutely. It's definitely not required, but if there's an opportunity for folks to show up, just let me know if you're going to be there. While we won't have an official meeting because we have it in July, it would be nice to have conversation. So
you might be able to have a work group meeting there if you get for folks interested in this diversion piece. We could probably accommodate that if there's interest.
Absolutely, if folks show up, not required, but just that I'd share that it is scheduled and is a little bit closer, not much, but a little bit. So. All right. Well, everyone have a great rest of your day, great Monday, and let me know if you're interested in the work group, and I'll be here. You'll be hearing from me. Thank you all. Have a great day.